Thank you very much. It's a great pleasure to be here. I first came to China in 1998. We did a preceptorship in Shanghai. At that time, the excitement was about statins. In that decade, we had numerous trials showing the benefit of statins, and it's not surprising that the guidelines have focused on statin therapy. In 2013, the ACC guidelines talked about 4 major statin groups: people with clinical atherosclerotic cardiovascular disease, very high levels of LDL cholesterol, diabetes, and also high risk primary prevention. And they also discussed statin dosages because there had been some trials that have shown that high-intensity statins were better than low-intensity statins for people with atherosclerotic cardiovascular disease. So these were guidelines that were in the United States. However, relevant to China and Asia in general are some issues in regards to pharmacology and side effects of statins. This came out with the data, with the trials of rosuvastatin, that essentially what ends up happening were mechanisms not totally understood. You get about a 2-fold increase in the AUC with rosuvastatin in Asians. Now, after the statin trials were the non-statin trials, and those came a little bit later. The first big one was we have another major trial is in progress. This is the Odyssey outcome trial. It's also a large global study, 18,000 men and women. It's slightly different. This was people who came in, they've had an event, so it wasn't all early ACS, but they've had a myocardial infarction before a study, including people who had CHD and different clinical criteria with it. And this study will have a longer duration of follow-up, which will be important. The 4-year study was very short, median duration of only 2 years. And it will be, this was, initially it was going to go later to this completion. So what do we know from the completed studies with the PCSK9 inhibitors and ezetimibe, and I didn't mention one other one, anacetrapib, and the reason being is that Merck has announced officially that they are not going to pursue approval for anacetrapib, so it will never be available clinically. What we do know is that lower is better for cardiovascular outcomes. The longer duration of therapy was also better. We have not seen a safety signal for very low levels of LDL cholesterol, even going down to less than 20 milligrams per deciliter, 0.5 millimoles. Now, the absolute risk of the patient, plus the amount of LDL reduction, can be used to predict the absolute benefit of therapy. So how does this tie into guidelines? Now, there has been some discordance between the European guidelines, I saw the Chinese guidelines, and the ACC, AHA, and I'd like to have you consider the concept that all of them agree that LDL cholesterol is the target of therapy. That is a consensus of all guidelines. There's an issue of the goal, which is the number that's used to assess the success of therapy. A newer concept of this is an LDL cholesterol threshold. That could be a percent reduction or a number, which you can then use to evaluate what to do next for specifically for non-statin therapy. Now, the American College of Cardiology has had, I've been part of an expert consensus panel. This was published just recently in September, which is an update on expert pathway. And one of the concepts here, this has been now includes the data from 4 years, 5 months, 5 to improve it. And one of the issues is that you can use the difference of the goal versus the threshold. So, if you have someone on a statin and their LDL cholesterol's over 70, or they're non-HDL, then one can consider what to do next. So basically, you need to optimize lifestyle, diet and exercise. Very important thing, if you see someone and their numbers are not optimal, is the issue of adherence. Are they actually taking the medication? Because very frequently they're not, because there are lots of different medications. Simple things like a pill box. Another important thing is to make sure you optimize other risk factors reduction. We've heard today about blood pressure, smoking cessation. So these are very important things. Even if you're having trouble with someone perhaps not wanting to take a higher dose of statin, you can work on those. You try a different statin and you try to maximize the statin. Now, if you have not been able to, and their LDL still, for example, over 70 or over 100, then you make a decision in terms of what can you do next. And we point out that there is now evidence in the higher risk patients that one could use ezetimibe or a PCSK9 inhibitor. Now, the difference in the threshold versus the goal. If the goal is less than 70, if the person's LDL 75, that means if you get to 65, you have met your goal. But did you really reduce the events much? No. And there's no scientific reason. Now, if we don't know the optimal level, it looks like you should, if you want to have further event reductions, you should try to reduce LDL essentially as much as you can to do it safely and affordably. So it's a different issue of a threshold versus a goal, and I think it's one that actually makes more sense when you're considering adding non-statin therapy than simply a goal, because we haven't seen a level that's optimal. The level that's optimal seems to be as low as you can get. It's really the concept of when do you add something, and this is the discussion that's done between the physician and the patient with considerations in terms of what do they want to do, injections or pills, and also availability and cost of therapy. So in conclusion, we have evidence of clinical trials now that clearly show lowering LDL cholesterol in high-risk individuals is beneficial. All the guidelines recommend initial therapy with statins. As some special issue in Asian patients, it's imperative that they should be included in all of the larger trials. We've had surprises in the past, and there's importance in terms of looking at both the efficacy and side effect profiles of different drugs in different populations. We saw this particularly with statins and niacin. Non-statin therapies, ezetimibe and PCSK9 inhibitors, and anacetrapib have recently shown to reduce cardiovascular events when added to statin therapies, consistent with the amount of LDL cholesterol reduction, and with these agents, it was shown to be safety in Asian populations. So one of the important things, you heard it earlier today, and I'll issue, if we look at the cardiovascular disease being the leading cause of morbidity and mortality in society, cancer being second, we know a lot more about the prevention of cardiovascular disease than we do for prevention of cancer. Yes, smoking and cancer. There's lots of cancers that people get, and we don't know why they get them. I've had cancer, I had lymphoma. I don't know why I got lymphoma. Fortunately, I was treated. But in terms of cardiovascular disease, we do know that we lower blood pressure. If we stop smoking and we reduce LDL, we can have dramatic reductions in cardiovascular disease, and the plea that we do this in both secondary and primary prevention. Thank you very much.